Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. A Level 1 trauma center like Upstate University Hospital is equipped to provide comprehensive 24/7 care for patients with severe injuries, along with additional teaching and prevention responsibilities. Today, I'm talking about trauma with Nurse Melaina King. She's the trauma program manager at Upstate. Welcome to the Informed Patient, Ms. King.
Hi, Amber. Thanks so much for having me.
When we talk about trauma, what injuries count as trauma?
In my world, we're talking about physical trauma. So, a physical injury, everything from a minor broken bone to what we would also call a polytrauma. So, in other words, maybe they have a broken bone, some internal organ bleeding, a head injury, etc. Now, that's not to say we don't recognize mental and emotional trauma that's often coupled with physical trauma, because we do address that too. But when we say trauma center, we're talking about physical injury.
And what is the most common cause of traumatic injuries?
Our top three causes that we typically see are things from like slips, trips, and falls, motor vehicle accidents. So that could encompass a car, a motorcycle, or even a recreational vehicle. And also violence. We do see everything, though. There are many ways to get hurt.
Now, Upstate is a Level 1 trauma center. Can you explain what that means?
Yes. So not every hospital is a trauma center, and every trauma center is not the same. There are levels. So the hospitals that are verified trauma centers, they rank in most states from level 3 to level 1. Level 1 is the most comprehensive, and that's what we are. So level 1 centers have a long list of standards they must meet to achieve that ranking. Those standards account for the resources we have. Like you mentioned, we have 24/7 availability of pretty much every surgical and medical specialist. We have to have things like cardiopulmonary bypass, continuous renal replacement, neuromonitoring equipment, but it doesn't really stop there. So in addition to those resources, we have a responsibility to engage with our community and do things like injury prevention programming. Trauma doesn't really happen just in Syracuse. We get patients transferred to us from everywhere. So we work with our region's EMS agencies and other hospitals to provide education on how to care for critical trauma patients. We do a lot of research and provide education to our teams. And perhaps most importantly, we have a very vigorous system for performance improvement. So in other words, when things don't go perfectly, we review it, we fix it, and come out stronger.
So let me go back a little bit to the level 1, 2, and 3. Are there some emergency departments that are not trauma centers, or are they all at least level 3?
There are some that are not. So
Okay.
in order to be any level 1, 2, or 3, you have to go through, it's kind of two pieces. There's a verification process through an organization called the American College of Surgeons. And then based off of, at least in New York, based off of that verification, the state will designate your hospital as a trauma center of that ranking.
And I understand you have a wide array of specialists that have to be available basically to handle anything that comes into the hospital needing emergency care. What is a critical care service, though?
Critical care service is for really when a patient is in the intensive care unit or ICU. These are the sickest, most injured patients. So our trauma surgeons are all board certified in critical care, and they, along with a couple others, staff our surgical ICU here, which is typically where our trauma patients go, which is pretty unique to trauma centers. We also have a neuro ICU, which is pretty special. So we have neurocritical care doctors there too. But this also means we have nursing staff and other professionals that are trained in critical care. So they have very advanced nursing skills and knowledge in order to care for the sickest.
Now, what region does Upstate cover with trauma care?
A very large region. It's 14 counties, which equates to roughly 1.8 million people in central New York. This region spans from, up north to the Canadian border to down south to the Pennsylvania border. And that's not to say we don't take patients from outside this region, because we often do. But that's just our marked catchment area, so to say.
Now, you mentioned that there's research involved. Can you give some examples of research that's been done on trauma?
Yes. So just thinking recently, some team members have published on topics such as the clinician role in reducing gun violence, management modalities in hemothorax in young patients. Hemothorax is like bleeding in the lung, trauma surgeon staffing models, mental health for trauma patients. Our neurotrauma partners have also been involved in a very exciting clinical trial that looks at brain oxygenation and its use with monitoring patients after traumatic brain injury. So a lot of really great things.
Interesting. Now, what does Upstate do to promote trauma prevention?
We take prevention very seriously. As I mentioned, it's one of those things that we are essentially tasked with as a level 1 trauma center. So much so that we do have actually a dedicated injury prevention professional on our team, a really great one that I'll add. And their job is to work with the community. So we'll look at our trends in injury patterns, and target those things. So, for example, if we're seeing a lot of car crashes in a certain area code or intersection, we can work with that. So we can implement programs or work with community partners to make those intersections safer, whether that's through engineering or whatever it is. One example of programming that we do, we have a program called Let's Not Meet by Accident, which is kind of a play on words, where we work with schools, EMS agencies, police, fire, even air medical, to put on a mock crash for students and talk about the consequences of distracted and impaired driving.
This is Upstate's The Informed Patient Podcast. I'm your host, Amber Smith. I'm talking with Upstate Trauma Program Manager, Nurse Melaina King. Let's talk about national benchmarks as a way to measure how Upstate is performing with trauma care. What is TQIP?
So TQIP, or TQIP, is a national benchmarking program that Upstate participates in as a trauma center. So there's about 900 participating trauma centers in TQIP. And what we do is we look at things like outcome and other metrics, essentially, to see how we perform.
And how does Upstate rate, like compared to those other 900 trauma centers?
So I'm really proud to share that Upstate now ranks in the top 10% of all trauma centers for survival after injury. So in other words, if you are critically injured and you come to Upstate, your odds of surviving are higher than 90% of all trauma centers in the country. Like I said, there's 900, so it's a really big deal, because we already know our odds of survival are greatest at a trauma center. But now, out of all of the trauma centers, Upstate is among the very top. And I think that's awesome.
Yeah, congratulations.
Thank you. It's really a testament to all of the amazing people we have here caring for our patients.
I'd like to have you walk us through what typically happens. How does the emergency department prepare when it's notified that an ambulance is headed your way with a patient from a car crash, for instance?
So we will know ahead of time, typically, because the ambulance crew or EMS providers will contact our emergency department physician and give them a brief report of what's coming. So then that emergency department physician will then determine if that patient is essentially more of a stable patient or a trauma activation needs to be called. So that trauma activation is an internal alert that goes out to many people, to our trauma team, and everyone on that team then essentially rushes to the trauma bay to receive this patient and be there when they arrive. So this would include an ED or emergency department physician, a trauma surgeon, trauma nurses, a whole pit crew, if you will, to work up this patient. And then that internal alert also prepares our whole hospital. So a CT scanner is held, an operating room is held, or an ICU bed is made available, things like that.
So what's the priority when the patient gets into that room and is surrounded by, I like how you described the pit crew. What is their priority?
So the way we work on trauma patients is extremely formulaic. So everyone has a role, everyone knows kind of the flow of that care. But the first thing when a patient arrives is we have this very brief timeout to listen to the EMS crews report, make sure we get the whole picture, and then we'll get the patient off the EMS stretcher and onto ours. We'll then focus on the most severe life threats first. So does the patient have uncontrollable bleeding? Do we need to place a tourniquet or hold pressure on bleeding? Does the patient have a stable airway? Do they need a breathing tube? All of those things, all the while someone is concurrently communicating with the patient if they're awake, or communicating at least with their family, because that's so crucial.
Do the paramedics usually bring the person's backpack or purse to the hospital? Because I'm wondering, how would you identify the person?
Yeah, so most of the time, yes, a social worker is part of that pit crew I mentioned earlier. So they're using whatever they can to identify that patient and their family in real time. So if they have a wallet or phone, those things are really helpful in figuring out who our patient is.
How important is it to find a loved one?
It's super important. And, most of the time, like I said, our care is very formulaic and we're focused on life threats immediately. But those family members are crucial because they can help us fill in the pieces. So, for example, their past medical or surgical history, any allergies, when they last ate, all of those things.
Are there treatments that you can't really do unless you know the past medical history or the medications the person's taking?
Sort of. In really severe scenarios, when a patient is unconscious and we have very little information, we proceed with what we call implied consent. And that is essentially that we will do everything beneficent in our power to keep that patient alive. So, things an awake person would normally have to consent to, so surgeries, blood products, procedures, we now assume that consent because if we don't, they could die. And then your other part of that question. So if a patient is on blood thinners, for example, at home, Coumadin's a common one. We might not know that if the patient is unconscious. So we might not immediately know to give a reversal agent quickly. So, there are things like medical profiles on cell phones now that people can fill out, or people carry around medical alert bands or medication lists that can be really helpful.
Trauma, it sounds like, would be painful. So I'm wondering how much of trauma care is pain management.
Yes, trauma is painful. And that pain is different for everyone, but we assume everyone is in pain and treat them for that pain the best we can. And we have lots of modalities to treat pain. So from medications, epidurals, nerve blocks, we even offer patients things like distraction. So we have video games and other innovative ways to kind of help patients, you know, work through some of that pain. We have a dedicated pain management team here of pain specialists, physicians, and advanced practice providers who will work with these patients to get the right combination, so to speak, of treatments for that.
If a patient needs surgery, how quickly might they be in an operating room?
Right away. So, along with the standards I mentioned, we have to meet as a level one trauma center. We have to be able to show that a patient can be in an OR at least within 15 minutes if needed. So we have a process for that. We have an internal alert essentially that our OR gets, our operating room, that says, hey, this is one of those 15-minute patients. Let's go. And so we can make that happen. And an OR is always available for a trauma patient should they need it.
Do you know what percent of trauma patients end up getting admitted to the hospital?
So we have around 3,000 trauma patients that get admitted to the hospital each year, which, really does kind of put us on the higher end as far as trauma centers go. We have a very high volume, and I think that's really in part due to the large region we cover.
And how long might a trauma patient stay hospitalized?
Typical length of stay for a trauma patient is usually somewhere around 4 to 6 days, but of course it depends on the severity of injuries. If it's something really minor, they might be in and out within a day. But for patients, the polytrauma patient that I talked about, sometimes certain conditions take longer to heal. So a traumatic brain injury, for example, or if they have lots of injuries, it could be longer. And then it also depends too on availability of, are they going to rehab after their hospitalization? Are they going to a nursing home? Lots of factors at play, but we have case managers and social workers who are involved really from day one to help that process go smoothly.
Well, Ms. King, this has been very informative. I appreciate you making time to tell us about trauma care.
Thank you so much. It's my pleasure.
My guest has been Nurse Melaina King, the Trauma Program Manager at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.